Welcome to today's webinar entitled When TB is the Least of Their Worries, TB and Refugees, sponsored by the Southeastern National TB Center. Today's speakers are Dr. Susan Cookson and Dr. Susan Maloney and Allison Hoskins. Dr. Susan Maloney is the Chief of the Global Tuberculosis Branch in the Division of Global HIV and TB at the U.S. Centers for Disease Control and Prevention. She is responsible for overseeing CDC's global TB portfolio and strengthening programmatic and research collaborations to increase impact on global TB control and prevention efforts. Prior to taking on her role in global TB, Dr. Maloney was the director of CDC's Southeast Asia Regional Global Disease Detection Center and International Emerging Infections Program located in Thailand, and worked with national and regional partners and WHO to strengthen surveillance, laboratory, research, and response capacities for emerging and re-emerging diseases. She is board certified in pediatrics and pediatric infectious diseases. She is a graduate of the CDC's Epidemic Intelligence Service, EIS, Fellowship, earned a master's in health science and public health policy from Johns Hopkins University School of Hygiene and Public Health, and is a captain in the USPHS. Dr. Susan Cookson has been at the U.S. Centers for Disease Control and Prevention since 1995, joining the Global TB branch a year ago as the lead of the Vulnerable Populations team. She started her love of TB as a physician in Nicaragua in the late 1980s. She has continued to work peripherally in the TB area, working at the DeKalb County Pulmonary Clinic for half day a week for almost 20 years. She has traveled extensively in Latin America, Africa, and Asia, working with displaced and refugee populations, developing monitoring and evaluation frameworks for refugee health services and surveillance systems, training young scientists, and performing operational research. Susan is a board certified in internal medicine and infectious diseases and a specialist in preventative medicine. She is also adjunct associate professor at the Global Health Department, Rollins School of Public Health at Emory University. She has written over 50 peer-reviewed articles. Allison Hoskins started at CDC in January of 2018 as a student worksite experience participant, SWEP, in the Global Tuberculosis Branch, GTB, in the Division of HIV and TB. Allison graduated from the University of Georgia in August of 2018 with a Bachelor's of Science in Health Promotion and Behavior, as well as a certificate in Global Health. In September of 2018, she started as an ARISE Health Communications Fellow in GTB. Allison is currently working as GTB's Health Communications Coordinator and works closely with the Office of Branch Chief and in collaboration with DGHT's Strategy, Policy, and Communications Branch. Allison has a passion for global health, equitable health across access globally, and vulnerable populations, and ending the TB epidemic. Today's moderator is Dr. Connie A. Haley. Connie is an infectious disease physician trained at Vanderbilt University. She has worked in TB since 2001 and currently works as a medical consultant for the SNTC. Now I will turn it over to our presenters. Thank you.
Okay, good morning, everyone. My name is Dr. Susan Maloney, and it's really a privilege and an honor to be here to speak to you today. We're going to be talking about when TB is the least of their worries, TB and refugees. So I thought first we would just talk about the objectives of the session. Tuberculosis and complex emergencies, the reality for refugees. We have three objectives. The first is to review the epidemiology of globally displaced populations and global TB to identify interventions to decrease the risk of TB disease and infection among refugees. The second objective is to learn challenges faced by refugees prior to U.S. immigration in order to improve health providers' engagement with patients in TB care and prevention. Our third objective is to discuss what U.S. clinicians should know about refugees for the purpose of improving health outcomes. So we have our first polling question. And the question is, how many of you have ever worked with a refugee who has had either TB or LTBI? Please let us know by a raise of hands.
I don't know if you guys are seeing this, but quite a few people have raised their hands. Seems like over half.
Okay, great. Okay, well then some of this may be repeats for others. So let's move on and talk about the problem of population displacement. It's really unprecedented. The numbers of internally displaced persons and refugees rose to staggering levels around 4 to 5 years ago, starting in about 2015. And these numbers continue on a rising trajectory through this year with headlines like this. The UNHCR refugees number reached highest ever recorded. From Smart News, more people are forcibly displaced than ever before. And lastly, refugees and displaced people surpassed 60 million for the first time, UNHCR says. So let's take a look at the figures if we can, the most recent figures. UNHCR has reported that there are currently almost 70 million people worldwide who are forcibly displaced. You can see that figure there, and then if you look underneath, we've broken it down, if you will, in some categories. 40 million of the 70 million are internally displaced persons, and this means that these persons are displaced in their country of birth or citizenship, and they don't cross an international border with their displacement. Then additionally, there are over 25 million who are refugees, and these are persons who have applied for protection and been accepted by a second host country. There's also another 3 million that are asylum seekers. And this population often has faced similar situations to refugees, but asylum seekers have fled their country and entered a third host country before they apply for protection or asylum. And then let's take a little bit, if we can, deeper look at the reasons for population displacement globally. The major reasons for population displacement are conflict, violence, and disasters. In 2018, a global report on international displacement from the Norwegian Refugee Council reported new displacements for 2018, and we saw those figures. But here we have data on about 31 million of the 40 internally displaced populations. So conflict and violence have caused new displacements in almost 12 million in 2018. And the conflict and violence are causing the largest displacements in sub-Saharan Africa and the Middle East, where, as we soon will discuss, many refugees originate too. For internally displaced children, populations, sub-Saharan Africa accounts for 46% or 5.5 million of the global total, and the Middle East accounts for 38% or 4.5 million. As far as internal displacement from conflict, you can see that of the countries in sub-Saharan Africa, 5 account for the majority: DRC, Somalia, Ethiopia, South Sudan, and CAR, with ongoing famine more of a problem than Al-Shabaab at this point. And then as far as disasters, if you look to the bottom of the slide, disasters cause new displacements for almost 19 million. East Asia and the Pacific remain the most disaster-prone regions globally, with 45.8% or 8.6 million displaced in 2018. Let's take a little bit more of a look at refugees globally, if you will. Of the over 25 million refugees annually, where are these almost 30 million refugees coming from? Well, 57% of refugees worldwide come from 3 countries: South Sudan, Afghanistan, and Syria. These refugees are staying and being hosted by countries in Africa and the Middle East, as you can see in the top refugee hosting countries. And you can see that the areas, some of the areas that refugees come from, are also overlapping with internally displaced populations. For refugees, it really should be noted that the populations are not only or primarily made up of adults. In fact, the majority of refugees are children less than 18 years of age at 52%, and an increasing number of unaccompanied children who are separated from their parents or their parents have been killed in conflict, and this number is increasing annually. Just wanted to give you a look at global displacement by year so we can see some of the trends. And this is the trends over the past decade. Note that the trend is increasing overall, and also note that the number of internally displaced persons plateaus in about 2015, with refugees and asylum seekers, which are in dark blue and green, continuing to increase to this date. So now that we've talked a little bit about the epidemiology of global, of the internally displaced and globally displaced populations, let's talk a little bit about TB and epidemiology. I think everyone, many know that TB claims 1.6 million lives a year. And actually, if you calculate that out, it comes out to about 3 deaths per minute. It's incredible. TB is such a global burden. We have 2 billion persons infected globally and about 10 million cases that occur annually. Just to note, this 10 million is an estimate from WHO, and actually we only have about 6 million persons that are reported through national notification systems. And that kind of underlies, if you will, some of the drivers for the global TB epidemic. The first being missed TB. So as I just stated, more than 40% of all TB cases go undetected or unreported annually. And for children, this percentage probably rises to about 60% of childhood TB cases are missed right now. Some other major drivers around the TB epidemic are weak healthcare systems. Patients are not being referred or treated effectively, which contributes to the growing threat of MDR-TB. And with recent data, we also see that we're having primary MDR-TB, so it's being transmitted person to person as well. Another major driver is the TB-HIV co-epidemics, especially in the African continent. And finally, the last driver is drug-resistant TB, when we had close to 500,000 cases reported last year. I say we largely attribute also a lack of political will and inadequate investment in new technologies and tools and approaches as a major challenge for global TB, but not to paint gloom and doom only. I think we're coming into our own to a new era. We just all participated in the UN high-level meeting on TB in September of this year, and we have new global targets and new commitment, and I want to say new enthusiasm around global TB. And so we're really looking forward to lots of good work getting done in the next couple of years. Just want to underline, if I can, that TB is the #1 infectious disease killer globally. It surpassed HIV for that honor, if you want to call it an honor, 2 years ago. And just to say that TB is also the major cause of death among people living with HIV, or TB accounts for approximately 40% of deaths for people living with HIV. And then just to discuss a little bit the geographic trends for global TB, you can see of the 10 million TB cases estimated in 2017, the majority occur in Southeast Asia and Africa. And if you then overlay the map of global conflict with the map of TB, you can see that there are large areas of overlap between high burden TB countries and regions and internally displaced populations in Africa and parts of Asia. But also note there's not such an overlap in the Middle East. But we will have to say that internally displaced populations, including in the Middle East, can cause changes in TB epidemiology in low and middle burden countries that we'll be talking about a little bit. I think I'm going to turn this over now to my esteemed colleague Susan Cookson so she can talk a little bit about her work on the impact of emergencies on TB.
Thank you, Dr. Maloney. So I think as Susan has well put together, we know that there is a large impact of emergencies on TB. And before, as she made the mention, before the Arab Spring in 2010, most of these emergencies were happening in Southeast Asia and Africa. So what happens when we have these emergencies? Well, there are increases in TB incidents that result from rapid influx of persons from countries where there is a higher TB burden. We're seeing that to some degree throughout all of Africa as well as the Middle East. These higher prevalence rates may be due to some degree increased detection. When there are emergencies, there are NGOs, non-governmental organizations that rush in and try to help. And thank goodness some of these non-governmental organizations are realizing that TB is an important thing to pay attention to. So there is some increased detection in some of these emergencies. However, despite these NGOs, there is some disruption in the treatment that is occurring. And as a result, there may be higher rates of TB-associated mortality, as well as drug resistance TB among these displaced persons. And here you can see the mayhem that takes place with these emergencies. This is actually from 2 decades ago, but it shows you what happens in some of these border countries. This is on the Turkish border that was taken by our colleague, Mike Toole. So now let's go ahead and look at our our case. This is someone that I got to know very well. Sorry, we had a change. Very well in the clinic where I work. Mr. JM was a previously healthy Liberian refugee. He was estimated at 54 years of age, and he presented to the pulmonary clinic one day after being discharged from the hospital. I say estimated because those of you, and it sounds like well over 50% of you, have worked with refugees. So many of the refugees had their date of birth January 1st. So there are not good vital statistics in a lot of these places where our refugees come from, and there was no exception for our refugee that we're talking about today from Liberia. So while he was working on the day of the hospitalization, he collapsed, and this was associated with a worsening of his right-sided paretic chest pain and some shortness of breath. However, he did not lose any consciousness, and it wasn't associated with dizziness. As far as the history of his present illness, about 3 weeks prior to this hospitalization, he had been experiencing, as I said, right-sided paretic chest pain, and actually described some real shaking chills, which was, I think, alerted all of us to thinking that maybe more than one thing going on here. Early in the evening, around 4 o'clock is the way he described it. He said he did not have a productive cough, but he had had one for several weeks, and he had known an unexplained weight loss, quite a substantial weight loss. Despite this, he continued to work because the labor that he was doing did not allow for him to have any sick days with pay, so he continued to work despite this. So the first polling question, or the next polling question I'd like to ask, is what challenges may affect whether this refugee seeks medical care for his symptoms? And I think I raised one just now, but what else do you think is going on?
So Susan, this is Connie Haley. I'm so glad that the three of you are providing this webinar for us. And the poll is in progress right now. I can see that about 30% of individuals have voted, and that's raising. If you'll give it just another minute, I think we are just about at 50%. And so Linda, why don't you go ahead and close the poll now? Thank you. Susan, would you like to read the responses?
Man, I can't. Sorry, I can't really see it. So can someone else read them for us?
Yeah, this is Connie. I'd be glad to do it. So the question is, what challenges may affect whether this refugee seeks medical care for his symptoms? The first question is fear of modern healthcare providers, doesn't know where to go for help, stigma or fear of learning the diagnosis, does not speak English very well, or all of the above. And over 95% have chosen all of the above. Would you like to discuss those results a little?
Sure. This was actually somewhat of a quick. There's no right answer to this question. Actually, he's from Liberia, and any of you who know the history of Liberia, he actually speaks English very well. That's his native tongue. So, but all the others are very much true. Though refugees do get a medical examination when they come into the United States, and he did as well. That's just one place that he went to, and he has not seen a healthcare provider after that initial time. So I think the fear of the healthcare system within the United States and the providers is probably real. Where to go, as I said, they do come in and get a medical examination, but whether or not that is where he should have gone for the TB, the possible TB treatment is a real concern. Stigma and fear is always a real concern, and Allison's going to be talking about that some later in the talk. So I think it's a little bit of a trick question. I'm adding in number 4 because, as I said, that's his native tongue. Thank you. So moving right along to continue, Mr. JM's past medical history consists of having had malaria, and he was a former tobacco smoker. As you know, tobacco smoking can increase your risk of TB. However, he had quit smoking easily 5 years before this current time. And he had an overseas medical examination in February 2010, and the only thing that it showed was that he was nearsighted. He had myopia. He showed no signs at that point of TB disease and actually had denied any previous TB exposure. Once he came in the United States in 2013, he received all of his adult vaccinations. He also underwent examination of his stool for ova and parasite, none were found. He did get a quantiferon, which was positive with a normal chest x-ray at that time. Reviewing his records now, basically 3 years later, we find out that there was no treatment at that point given for him for latent TB infection, basically a missed opportunity. So continuing on about his social history, Mr. JM had been tortured for an entire month in 1990, and following that torture in Liberia, he was forced to actually witness the killing of family members. He didn't want to talk about this much, but he did mention that to me when I first met him. He subsequently got out of Liberia as quickly as he could. He ended up going in transit to Ivory Coast and eventually ended up settling in a Ghanaian refugee camp, and that's where he got identified and received the Department of State refugee status for what he had gone through. He subsequently, once he got the refugee status, underwent further security and medical clearance for U.S. resettlement. As I mentioned before, his primary language is English, and he had completed a third-grade education. Once he came into the United States, the resettlement agency was able to refer him for mental health evaluation. We do have that capacity at the county health department, or did when he came in. So he was evaluated for mental health. Moving forward, so as I mentioned, I saw him the day after he got hospitalized. And when he was on the workup in the hospital was basically he had stable vital signs, and his weight was 112 pounds. He's about 5'6", about my height, but extremely thin. And The general impression was that he was a pleasant, awake, alert, and oriented with no obvious respiratory distress at that point, and was speaking in complete sentences. He was a lovely man. He truly was. His lungs were clear and he had no other abnormalities noted. In the hospitalization, they were concerned about the possible TB and actually placed him in isolation. They offered him HIV testing and that was negative. And in the hospitalization, he had a CAT scan performed, which reported atypical appearing infiltrates in his right upper, middle, and medial lower lobes, and actually had 2 cavities that were thick-walled in his right upper lobe. The first day of his hospitalization, they ordered sputum for asparagine bacilli, and it came back for positive. He was in the hospital for 3 days and then was just on treatment and then was discharged to our county clinic. So at the clinic, I saw him on the 23rd of June. At that point, he complained as far as review of systems, loss of appetite and weight. He then did complain of some dizziness, though he had denied that when he collapsed, and he continued to have the cough associated with pleuritic chest pain. His weight had not changed in spite of, or probably because of 3 days of being in the hospital. He was still 112 pounds. His lungs were clear. He was tachycardic, however, and his abdomen was totally benign. So we continued him on his RIPE treatment, rifampin, isoniazid, pyrazidamide, and ethambutol, along with B6, through directly observed therapy. And here you can see his chest X-ray, and that was taken on the 23rd. And as you can see, it's quite obviously has extensive infiltrate going on in that right upper lung field. So the next polling question to you is, what factors might have increased his risk of TB prior to U.S. arrival? So I'll open it up for polling.
Yeah, so this is Connie. It looks like the voting has started. I'll just read through the selections while we wait. The choices are limited access to health care or nutrition, time spent in crowded congregate settings, alcohol and tobacco use, and more than one of the above. We've got about 60% voting so far. I think, Linda, I think you can go ahead and close the poll now. And Susan, I don't know if you can see the responses, but it looks like more than 95% of our audience has chosen the question, the response, more than one of the above. So you can go ahead and remove that quick poll, and we'll let Dr. Cookson describe the results.
Yes, I agree that more than one, and actually all of them, as you have said, have led to his having been at greater risk of progression to TB disease. The one thing that he did not have, thankfully, he was not HIV infected. So we were happy for that for him. So just talking about a little bit about the risk factors for having TB infection among emergency affected populations. And as we know, this is due to increased exposure during the migration or in detention or transit locations. We do know that Mr. JM went from Liberia through Ivory Coast and finally into Guinea. And we don't know that actual transit along the way. He wasn't, he was reticent about communicating that with us, and so we did not push that. Probably to some degree it may have been a very traumatic experience for him, so I didn't push that. And then of course, once he got into Guinea, I don't know how many of you seen some of the refugee camps there, but like most of them, the one that I had seen, the one where he was, and it was overcrowded when I was there back in the 90s. So I'm sure it was very overcrowded up until the point at which he left, which was in 2010. And there has been actually a recent study by Walker et al. That looked at 24 migrants that were from the Horn of Africa, and they used molecular genotyping and actually showed that that transmission occurred en route from to when they went to their asylum country. That was in Europe, and of those migrants, which could, in my thoughts, be classified as refugees. 55% of them were actually able to either name the specific detention center where they were or recall it. And these were people that were moved due to trafficking. So they were being held in these detention centers by traffickers until they were finally able to get into Europe. So now that we know that there's increased transmission, the obvious risk factors that affect any population potentially for going on to active disease are even more so among displaced persons. Malnutrition and total food dependency and food insecurity are very much a factor. Alcohol and tobacco abuse, this often happens due to the stress that's going on for them, as well as we mentioned before, co-infection with HIV. There are a lack or even a damage of what health facilities are there, which can lead to the increased inability for treatment adherence. Where there are facilities, they may be lacking medications, or staff may not be coming because of as Dr. Maloney mentioned before, the actual health system may be poor. There's low case detection. There's a higher loss to follow-up, and as a result of that, a lower cure rates, and all of this leading to the potential of chronic and multiple drug resistance. And there have been a couple of studies that have actually shown that when some of these displaced persons develop a chronic cough, they will use some of the non-regulated providers or pharmacies. Actually, Dr. Maloney and I did a study back in the 1990s when we looked at refugee populations, she's smiling at me, refugee populations for resettling in the United States, and saw that refugee populations did have a higher rate than other foreign-born, and there's been a more recent study that looked at that. I do want to bring a caveat to that remembering when we're ever looking at any of displaced refugee populations that make it into the United States, that these people do have, as Dr. Posey had brought out, do have and do use healthcare facilities upon arrival. So there may be some bias as far as active case finding among these populations, especially before the point of which they were required to get culture. So I think some of these older studies may be a little bit biased as far as active case finding. And the fact that there are now culture overseas has a lot to do with some of the earlier work of Dr. Maloney. All right, so moving on a little bit, what happened to our case? Well, he was given, when I saw him, a letter stating that he could not return to work. He was obviously infectious with having 4+ smears in the hospital, and he was to notify his employee that he would be unable to work for 2 to 4 weeks. He did request and received at that point assistance with his living expenses due to his self-isolation and his inability to work. The policy at our county clinic is to collect 3 sputums a week and continue that until a serial 3 sputums are negative. Okay. So let's just talk a little bit, a little diversion here, and talk about, well, what does happen for refugees overseas as far as what control programs are going on. And the UN, UNHCR, the UN Refugee Agency, actually this past year has asked us to help as far as evaluating some of the TB control programs. Three TB control programs in Tanzania, all 3 in Tanzania, as well as 3 of the 6 in Rwanda. And here I'm just showing you some of the data from Tanzania for one of the 3 camps. As you can see here, this one camp was set up in 1996. Refugee camps have been called warehouses. People stay there for decades and decades. And this was a camp set up for Congolese, basically well over 20 years ago. Looking at what was happening within that country, Tanzania has a case notification rate of 129 per 100,000, but in Kigoma, where this refugee camp was, the case notification rate was only 45. If we look at for last year, the Congolese that did have reported cases, 7 of the 35, or 20%, were among children. So the question is that mean that that adults are less detected and children are more detected, or that this is actually a good rate? I tend to think that it's probably that there's a low detection rate among both adults and children. And when we figured out the case notification rate using mid UNHCR figures, we found that it was 49, equivalent to that of Kigoma, which was 45. However, I don't think that these low levels are because there's less TB. I think there's probably less detection going on. And as Dr. Maloney said previously, there's at least 40% of cases are not detected. And then we look at Tanzania's estimated rate versus their notification rate. It's actually 55% in Tanzania of TB cases are not being detected. And so what we're seeing here is that for the Congolese, they are not being detected, their TB, equally as much as for the nationals within the country. Similarly, I won't belabor this. I think we're getting a little bit tight on time, but looking at, oh, I hit the wrong one. Sorry. Looking at the Burundi refugees, they did a little bit better. This is not a high burden country, Burundi. They have a notification of 70 per 100,000 and an estimate that's not double that. It's 118 per 100,000. So they were within the range as far as being able to do notification, at least for the Nuta camp. The other two did very poorly. And they, again, were probably missing a high degree of cases because only 59% are detected there. So just in summary, sorry, we had a little bit of technical issue here. Just in summary, okay, the rate among refugees is probably dependent on the number of years they're in the host country. So we think that the more interaction between the host and refugee populations probably means that the rates will be more like that of the host population, or if it's for a shorter period of time, more of that where the refugees come from. It actually has to do with whether or not preventive strategies are provided for refugees. And this is not only providing isoniazid for latent TB infection, but also thinking about infection control where the refugees are either getting care or in other kinds of mutual congregated settings, and then all the other risk factors that we mentioned previously. And equally as well, unfortunately, what we're finding is that TB control programs for refugees is usually only as good as that of the host country's population programs. So let's turn a little bit right now to the Middle East and talk about TB prevalence in the Middle East. If you see the upper curve there, the yellow one, which is actually Iraq, you'll notice that sharp increase. And basically, what we're seeing there is that this was shortly after the NATO attack on what was happening as far as trying to stop the invasion. And you suddenly see that when you see conflicts within a country, you're going to start seeing an increase in rate. So then what happened in 2011? Well, as we all know, that's when the Arab Spring, 2010, the Arab Spring started, but in Syria, that's when the conflict happened there. So what's been done as far as diagnosis and treatment in some of these protracted emergencies, and I'm just going to be focusing a little bit right now on the Middle East. In Jordan, in regard to the Syrian refugee crisis, up until recently, they had a single entry point, and the International Organization for Migration, or IOM, was able to perform screening at that one entry point. And they were able to question about past TB diagnosis and treatment, and also do a simple algorithm for screening for symptoms as far as pulmonary TB. They were then able to have the refugees that either had presumptive TB or reported that they had been on TB treatment, able to refer them to the National TB Center. In Lebanon, also in regard to the Syrian refugee crisis, IOM employed community health workers to conduct the mass screening, again using the algorithm, the standardized questionnaire, in the informal refugee settlements. In Lebanon, the Syrian refugees do not live in camps. They're among the host population. So they were employing the community health workers to be able to go where the refugees were settling and conduct these community-wide screenings. They also provided, IOM provided funds to transport the presumptive Syrian patients to the National TB Clinic, and if they were diagnosed with TB, also supported directly observed therapy counselors where these refugees were settled. In emergency kind of settings, there are a couple strategies that have been done very much by MSF, Doctors Without Borders. They've set up manada regimens, which basically means that the family at large is able to remain in a home style of setting during the treatment. The whole family comes, they provide the food, they do the cooking there. So in a lot of these situations, the husband or the provider loses ability to get treatment because he or she feels like she has to provide income for the family. And in this kind of situation, the whole family is able to come and the patient is able to get treated. Another thing that they've set up is basically, this is MSF, Doctors Without Borders, has developed a three-tier proposal where in an evacuation, if it's not a large disaster, then the international staff leaves alone. With warning, the whole staff and the whole community is leaving. And then if there is no warning, everyone still leaves as well. So these kind of scenarios. And during that evacuation, they receive this runaway bags with anti-TB medication that contains a month's worth of supplies, though the staff and the patients try to stay together as much as possible during the evacuation. This runaway bag was actually what's been used in Kenya as well during the post-election violence there in the late 2000s, 2007, 2008, as well as with Hurricane Sandy and with Katrina quite a while ago. So the United States has even done this. So what are challenges for TB control and emergency? Well, there's a general lack of awareness of the need. There's a lack of institutional development at large where a lot of these emergencies take place. As I mentioned before, there's a lot of non-governmental organizations that come into play, and there's difficulty of then transition to the national programs. There's difficulty ensuring compliance with the guidelines, and especially for the non-governmental organizations. The turnover is very large, and sustainability is a real issue. So there is criteria that WHO, World Health Organization, has set up for deciding to start a TB program, and it's basically if the burden is there, if the emergency is over, if basic needs and clinical services are there, at that point it can be determined whether or not there can be a control program established. And in the United States, as I mentioned before, the bottom one, the runaway bags have been done, but other things that can be happening in our countries, because we do suffer disasters, thank goodness, not violence, but disasters, is creating line lists of the patients. If you know ahead of time that there may be a disaster, so to have that, to ensure that each patient has the phone numbers in case to reestablish contacts. To ensure that there is a backup register of the patients, and to move essential drugs and medications to a safer place. So going back to our patient, as I mentioned before, he was smear positive. We were obtaining sputums 3 times a week, and even though he did have some negative ones in July, he ended up being declared still infectious. So the first sputum, so he was 1+ smear positive through July 29th and was not declared non-infectious until August 12th. Unfortunately, he did not notify his employer of his ongoing inability to work, and in fact had no communication with his employer. The policy within the county is only to write a letter to employers if the patient requests that, and he did not request that. The employer did not communicate with our patient until early August, when they told him that he no longer had a job. When he returned to the clinic in early August, he informed us that he had lost his job. I went ahead and communicated with the Human Resources Department and told them that he had an illness, that he should not be penalized for not being able to come to work. I wrote a letter to them as well and CC'd the county health department, the state health department. Despite this, his employer refused to reinstate him, and I let the state know of their inflexibility, but even with that extra push, they still did not reinstate him. So he was unable to find any employment nearby once he was non-infectious, and only after another month was he able to find employment 2 hours away from where he lived. So in total, he was unemployed for 6 months with no compensation, though only, for three months without any compensation, though only 6 weeks was he had infectious TB. And he completed his treatment 10 months after starting it. And as you can see here, except for a few scars in his right upper lobe, he did very well. I will now turn it over to Allison, who will talk about some of the barriers.
Yes, I'm going to take a deeper dive kind of into some of the barriers to healthcare that Dr. Cookson mentioned earlier that our case study patient ran into. One of the biggest ones is definitely stigma, not only related to being a TB patient, but also the huge stigma surrounding being an internally displaced person or a refugee. So studies have found that TB patients are expressing feelings of shame, fear of isolation, and rejection by loved ones, and even by the healthcare system. And this, in combination with stigma related to being a displaced person, it's associated with delays in seeking healthcare and those self-treatment behaviors that Dr. Cookson mentioned previously. Second is language. This is a huge one. Refugees are running into language barriers at every level of the healthcare system. This is filling out paperwork, understanding written materials, filling their prescriptions, taking their medicine regimens properly. And with lack of communication and lack of language translation services, refugees are more likely to seek lower quality of care just so they can be seen by a doctor that speaks their same language. And these perceived language barriers are leading refugees to either seek out healthcare services only when they're very sick or not at all. The next is acculturation difficulties. These refugees are leaving their friends, their family, everything behind. So already resettling into a new environment is very difficult for them, along with navigating a totally unfamiliar healthcare system. So they're having difficulty resettling due to cultural and environmental differences, especially after the journey they've taken. There's also perceived unfair aid distribution by healthcare providers, discrimination, and tensions with host communities. All of this resulting in negative, not only mental health outcomes, but also negative mental health outcomes for these patients. The next one, cultural beliefs. So culture is directly affecting refugees' concept of healthcare services. Culture here being defined as native belief systems, traditions, upbringing, social norms, and personal values. Their refugees' concept of healthcare services, prevention services, expectations of care, and stigma around health conditions are preventing them from seeking out care. There is a huge misconception of infectious diseases, a big surrounding. This goes back to stigma. There's a big fear of job loss, loss of rights as an immigrant, negative reaction from friends and family that is associated with a diagnosis of an infectious disease. And this also goes back to our case study. Mr. JM, whenever he received his diagnosis, there was a lack of communication between him and his employer. He actually didn't relay the information to his employer that he was ongoing communication between him and his employer about his disease status, which actually resulted in the loss of his job. So refugees know that diagnosis of TB can result in loss of job, so they're less likely to adhere to treatment, fully accept their diagnosis, share their diagnosis with friends and family, and especially their employers. There's also a misconception that refugees have of Western medicine. Our clinics are very different than they are overseas, especially if there has been some establishment of mistrust if they have not been diagnosed with TB overseas and they're being diagnosed here by a Western healthcare provider. And also prevention services. This is something that's completely new to a lot of people overseas, something that we're really trying to push. Screening and preventative services are some things that aren't even provided overseas for a lot of people. And then getting into some more logistical issues, cost is a huge one. When surveying Syrian refugees, actually, the number one barrier identified by them to accessing healthcare was high cost of healthcare services. They're prompting refugees to seek care from pharmacists solely, which can leave chronic conditions uncontrolled and untreated and can be a huge cause of what we were mentioning earlier, the antimicrobial resistance. Also, lack of insurance and gaps in coverage due to difficulty with enrollment in public insurance programs can be a huge barrier. And like I said, financial problems were identified as not only the biggest barrier for healthcare for refugees, but also one of the biggest contributors to additional stress for refugees, also, like I said earlier, resulting in those negative mental health outcomes. Another one is legal status and livelihoods. A lot of times during their journey over here, they don't have their birth certificate with them. As Dr. Cookson said, they're saying that their birthdays are January 1st. We don't really have any real records. That can make it very difficult for them to receive legal work once they come to the U.S. Lack of birth certificate can also lead them, they're going to be less, they'll think that they can't access the healthcare, discouraging them from even trying to access it, but this can also run into a lot of problems with insurance and coverage, making health care services really expensive for refugees. And on top of that, they're dealing with poor housing, poor nutrition, depression, poor hygiene, and poor access to healthcare, all wrapped into one. Some more logistical issues, transportation. This is really big. Getting to and from healthcare services. Sorry, I got tongue-tied there. Lack of transportation to healthcare facilities to and from refugee camps overseas is a huge issue. Some other ones, understanding of hours of service, wait times, appointment availability, childcare needs, and barriers around scheduling, and also change of policies about which clinics and hospitals are offering subsidized care for refugees. And then in addition to that, just in general, we're finding that refugees' main priorities when they're coming over to the U.S., the first thing isn't screening for tuberculosis or finding access to equitable health care. Their first things that they're worrying about are, do I have access to food? Can I find a legal job? If I have medicine, how am I going to access it? How am I going to get my child free education, and how am I going to take care of my child? And when asked what their perceived health needs and priorities were, the answer was generally acute conditions like respiratory illness, fever, diarrhea, and injuries, and chronic disease. There's also a huge push for mental health services and smoking cessation. And like I mentioned earlier, preventative treatment and screening are not a priority. So moving on to culturally competent care, what you can do as a healthcare provider, as a physician, when working with refugees on how to address all these barriers that we have mentioned previously. So just to start off with a definition, culturally competent care is defined as care that respects diversity in the patient population and cultural factors that can affect health and healthcare, such as language, communication styles, beliefs, attitudes, and behaviors. So when using cultural competency in the healthcare setting, it allows healthcare providers to deliver services that are respectful of and responsive to health benefits practices and cultural and linguistic needs of diverse patients. So one of the biggest things is to respect the whole individual and respond to the individual's health needs and preferences. This is critical for improving access to high quality care for refugees and reducing those health disparities, as well as establishing a trust between patient and provider. So this is vital when we're dealing with the refugee population, because after everything that they've been through, it's going to be very hard to establish that trust, especially with a healthcare provider. So as I mentioned earlier, lack of language and communication is a huge barrier to healthcare. So translation and interpretation services are necessary, but they're not complete solutions. So having just a translator or an interpreter is not where it ends here to providing culturally competent care, because you're not always able to provide fully accurate translations, and not all languages have words for certain words or things in other languages and cultures, making context and direct translation really difficult. So collaboration and communication are essential here. When translating services are provided, it is really important that interpreters or translators in these healthcare settings be specialized and trained in moving conceptually between Western models of disease and treatment and the unique cultural and medical beliefs of the refugee patient. So now here, and you will be provided with a handout that you can actually click on the hyperlinks for all of these. These are some actual links for some different resources that we found when providing on how to provide culturally competent care when working with refugees. The first one is the National CLAS standards. That stands for Standards for Culturally and Linguistically Appropriate Services. And these are national standards that cover a bunch of different areas. It's governance, leadership, workforce, communication and language assistance, organizational engagement, and continuous improvement and accountability. The second is just a guide to providing effective communication and language assistance. It covers strategies for communicating in a way that considers cultural, health literacy, and language needs of your patient and their families. The third is a link to the American Translators Association. It's really important for providers to go in here and select and match certified translators and interpreters with the correct audience whenever providing those for a patient. The fourth is a language access portal. This is a resource launched by NIMHD for people who have populations with health disparities and limited English proficiency. The fifth is the primer, which is actually a book. If you go in here, you can access the PDF file. It's a resource that health professionals and educators can use as a teaching resource for cultural competency. And then the last is the Center for Victims of Torture Protecting Refugees. It's an international nonprofit dedicated to healing survivors of torture and violent conflict. Moving on to the next, here's some more resources specifically when dealing with mental health when working with refugees. The first is the American Psychological Association's Refugee Mental Health Resource Network. The second is the Substance Abuse and Mental Health Services Administration. It's just a document listing a number of resources regarding refugee behavioral health resources. And the last is the Office of Refugee Resettlements Network Resources. This link has many resource links related to resettlement, integration, health, and economic development and employment. And then for these last resources, I'm going to turn it back over to Connie to discuss these. Thank you very much.
I have to thank all three of you for this just absolutely wonderful webinar. It's just exactly what we all need practicing in the front lines here in the U.S. And I will want to highlight some resources that we have through the SNTC and the other Centers of Excellence and also the CDC. And again, you all have the link here as well. Our website link is here. We have a number of products and tools in Spanish and many, many other languages. If you can't find what you're looking for, please contact us and we'll be glad to help you hone directly into what you're looking for. I want to also mention that the Curry Guide for Drug-Resistant TB, which is not only a wonderful resource for drug-resistant TB, but also has wonderful guide, works as a wonderful guide for any patient with TB. It has resources on the lab and on medication fact sheets and how do you monitor and how do you manage contact. So there's really a wonderful guide, and that is now available in Spanish. Our webinar that's been done today was preceded by a wonderful webinar by Dr. Drew Posey, also of CDC, and that one focused on the immigration system, and that one is archived on our website right now, and it goes through the overseas screening process and touches also on evaluation in the United States. I would just want to mention that we may come back and do a third webinar that sort of combines refugees and immigrants and talks through more of the issues that you might face in frontline practice. We'd like some input. So if you all have suggestions on what you still want to know or what you think hasn't been adequately covered, please send me, Connie Haley, or our SNTC office a message. You can also put it in the evaluation. And again, CDC has a number of fact sheets. There's the TB website, as well as the Immigrant and Refugee Health website on CDC, and then information on exams. If you could forward to the next slide, please. Also want to highlight that we have country guides for about 19 countries, and these are 3 or 4 pages, often providing information on the countries specifically, some of their epidemiologic data on TB and HIV, talks about common misperceptions and beliefs about TB and HIV and AIDS, and some of the general health practices, cultural beliefs and courtesies that you may want to observe. So if you know that a patient's coming in from a certain country for which we have a guide, it's a good idea to just peruse through those. We also have one-page brief overviews of a number of countries that you can find on our website. Next slide, please. This is our contact information. As you know, you can email us or call us. And if you need help with any specific patients, you can reach us through 1-800-4TB-INFO. We work 24/7 to answer calls as needed, and our sister Centers of Excellence, their contact information is located on our website as well. And so now I would like to turn to the questions that you all have put forth. Let me see if I can pull these out. Dr. Cookson, I see a number of questions that pertain specifically to your patients. I'll start with those. Someone wanted to know, in addition to the AFB microscopy from the sputums you collected, was this patient also tested for rifampin resistance or MDR-TB using GeneXpert and culture?
Yes, thank you very much for that question. And yes, at the state lab, they do PCR. It's not GeneXpert, but they do have a PCR panel, and he was immediately tested for rifampin, and he came back. They do rifampin and isonize it, and he did come back pan-sensitive, or at least to those two. And when the cultures were done as well, he was pan-sensitive to all 4 drugs. So we did stop him from ethambutol when we got the culture back. So we got stopped at about 6 weeks into the treatment from ethambutol.
I'd like to highlight as well that rapid molecular diagnostics are now the standard of care. And so if you work in a hospital or clinic setting where you don't have access to getting a PCR or a gene expert or Hind test to molecularly detect TB within a day or so, reach out to your state health department. Almost all state health departments have PCR, if not gene expert. And if you have any questions about that, contact your centers of excellence. Unfortunately, we too often see cases where they rely on the culture, and a hospital, especially in more remote settings, may not know to send off molecular testing, or it may get sent to a reference lab, which could take upwards of a week to report the results. And so again, connecting the community and academic health centers and other hospitals with public health laboratories is very expedient. Another question, go ahead, Susan.
And I want to bring out another point. He did not have the PCR done in the hospital. It was only once we saw him, but yet he did get this chest CAT scan, which, you know, given that he is from a rather highly endemic country, was a refugee, had some classic symptoms. I think it's a lesson for us that work in hospitals, you know, to think TB and to be able to save some of these more expensive procedures to do something simple like, as you're saying, a PCR that can be done at the state lab. So just wanted to reiterate that.
Yeah. Absolutely, and we've had a number of discussions at SNTC about patients who come in who are born overseas in TB endemic countries, and you know, really to all of us in public health, we think TB almost immediately. How there's such a delay, and it's often hard to even get sputums done before the patients are sent off for bronchoscopy. And as the national guidelines do recommend collection of sputum, smear, and culture first, molecular diagnosis, and do sputum second, and then bronchoscopy after all of those have been exhausted. And I think that's not well known. Susan, another question about your patient is that someone was curious about how you were able to get the financial assistance to help him during his time where he was not getting paid time off.
Yeah, the American Lung Society, we have an agreement with them at our county, and they do provide us some funding, as well as we can get them a $500 it's not even a loan, it's $500 that a card that they can then, I shouldn't be naming it, but they can get that at a local grocery store. So we do have that through the ALS. So we're very fortunate in the state of Georgia for that, or at least within the county where I work.
Yeah.
In fact,
and I would say some reach out to your public health, state and local public health.
And in fact, some of my patients have, and I'm sure some of yours as well, have not been refugees, but have been homeless. And so there's actually a apartment where infectious clients can stay during their course of their treatment.
So another question, I'll just answer a few more quick questions about the case, and then we have a number of questions now. One is if there were significant exposures at work, and if so, was there a workplace contact investigation? And the other question related to that was whether or not the patient disclosed that he was employed during the contact investigation.
Yeah, so we actually went back and forth as far as this. The patient works in a loading dock, so he was outside the whole time, and the only time that he was ever inside was when he was in the lunchroom, and he had a tendency of not eating lunch with anyone, though we did get a couple of names of people that he occasionally did have lunch with and notified them and tested them. He was forthcoming where he was working. It's just that once he found out he had TB, his communication beyond the initial stops completely. And I think some of that were for the reasons that Allison has outlined, the stigma that he felt.
Thank you. Okay, another question, shifting gears a little bit, and any of you guys are welcome to answer this, but the question is, what are the projections as to the impact of climate change on displaced and refugee populations? I think maybe this person wants to know more about the natural disasters and the impact that has on displacement.
Yeah, this is Susan again. Oh, I guess there are two Susans. Susan C. again. Yes, I mean, there has been, in fact, the last decade has been called the decade of disasters, and as Dr. Maloney made the point, Southeast Asia and the Western Pacific are the region of the world which is the most impacted by that. The most disasters go on there, and they've only been getting worse. But if you think about Africa and what's been going on as far as some areas having huge droughts, other areas having huge floods. And Somalia is a prime example of this right now, as well as what's going on in Ethiopia. There have been huge crop failures, which have led to huge displacement. I don't know if you catch it, but Dr. Maloney made the point that there were more people about 5 years ago fleeing from Somalia because of the drought, rather than the Al-Shabaab, which recently had an attack in Kenya. But it's resulted in huge numbers of displacement throughout Africa and, as I said, Southeast Asia. So, and we're only going to see it worse, as we are seeing in this country, and we're having to make plans thinking about hurricanes that hit our country and what we need to be doing for TB patients that live close to the coast.
Yeah, this is Susan Maloney. I'm just going to follow up that I'm not aware of formal kind of projections in terms of displaced populations for the future based solely around climate change, but certainly it's going to be a big driver. It already is, and it will continue to be for the future.
Thank you both for that. Another question we have is asking about the use of 3-HP, the 12-week regimen of isoniazid and rifapentine, and whether that's used in any refugee camp or for people found to be infected with TB who don't have active disease. And I might just expand that question a little more broadly. You referred to a couple of specific settings of refugee camps, but could you talk just a little bit more about how common it is to have TB services, including screening and active case finding, or offering contact investigations or preventive services, and also maybe mention the role not only of the host country, but of the UN and other NGOs that might come in, and even your group at CDC, and provide assistance in certain areas related to this?
Sure. This is the other Susan. So within refugee camps themselves, the UN Refugee Agency, UNHCR, does provide for TB services, and that's actually been going up quite a bit in the last 10 years. 10 years ago, when we first wrote the TB tool, UNHCR was not that interested in it, and suddenly that's what we've been using to evaluate the TB control programs within camps. So within camps, yes, it is well organized, and depending on country to country, there is a system of community health workers who basically do go and do monthly screenings of the community, and asking questions as far as cough. But unfortunately, or fortunately, the majority of refugees today are not in camp settings, and the majority are living with the host population. And in this kind of scenario, it's much harder to do screening and provide refugees with TB services. We're about ready to go to South Africa, which has a huge refugee population, and try to develop a tool for UNHCR to get an idea of the knowledge, access, and use of TB and HIV control programs for the refugees within that country. So it works in camps. It remains to be seen how much it is. It's supposed to be, there is a policy, it's on the books as far as refugees having access to both HIV and TB, but what actually happens in the reality, UNHCR doesn't have a strong understanding of that, and so we're going to help them with trying to get a handle on that and develop a tool for assessing that. As far as preventive care, everywhere that I have been, I have only seen isoniazid, and it's very, as far as preventive treatment, and it's very limited for refugee populations. Do you want to talk about Vietnam?
This is Susan Maloney. Just in terms of kind of the U.S., we have been working our branch in collaboration with DGMQ now for several years, looking at Drew Posey. You guys, I think he had a talk with you as well, but we were able to get some special funding, if you will, that came through a couple of years ago, working in collaboration also with UCSF to look at the feasibility of offering 3HP to immigrants in Vietnam. And so we're in the midst of that study right now, and also in the midst of discussions about could we do a similar feasibility study in a refugee, probably a refugee camp setting, but not necessarily, as you all know, if you've heard Drew's presentation and Susan just saying, the overseas screening and the U.S. stateside screening are big opportunities to both identify active TB cases and get these migrants treated, and also to connect them to preventive services and preventive therapy. So as we gather more information, we'll be able to feed that back to you.
Yeah, and as our Mr. JM, that was a real missed opportunity. He did have a positive quantiferon when he came in and had the assessment in 2013, and it was a missed opportunity then.
But in looking at
a couple of things.
Sorry, I was just going to say, in looking at data, and this is not an exact quote, but there is, we probably follow up and treat less than half of the immigrants and refugees stateside that probably need or could benefit from LTBI.
I think we do better with refugees.
We do better with refugees and immigrants. But in completion, we don't do that well either. So hopefully 3HP will help us.
I would agree. That is an absolute high priority, with more than 70% of our TB cases in the U.S. being born overseas, and many of them having had experiences similar to what you described. You know, I think, it's many places in the U.S. don't have the resources to actively go out into the community and find some of these individuals who may or may not show up or follow through. But if that can become a priority, then and ensuring that they're not only screened for active disease but given preventive therapy, I do think that would make a lot more progress limiting TB in our country, which will ultimately mean a lot less work here. I wanted to just mention a few housekeeping things. One is, I see a couple of questions about the handouts. If you look at your control panel, you should see something that says handouts. It looks like an arrow, and if you click it so it points downward, you should see 3 handouts that you can download. One was just housekeeping, which you may not need. One is the actual presentation, and one are the bios from our wonderful speakers. If you do not have that and you need these handouts, please just email us and we'll send them to you after the presentation is done. I also wanted to give a shout out that I see we have some participants from Greece and possibly the Ukraine. We're so grateful you joined us. Please continue to join. And then I'm just going to go back and continue to ask some questions. Again, we will continue to ask questions till about 12:30, and hopefully be able to get
Dr. Haley, this is Dr. Haley. Hi, it's Donna. Yes. Just so people know, there's several time zones we're dealing with here. So it is now 1:15 Eastern, and we'll go until 1:30 Eastern. Also, I am getting some resources from people that are texting us resources. I'm starting to share those in chat for everybody to have a link to those also. So be checking your, they'll come into you as in the question pane. So feel free to be checking those.
Okay, and also Donna, I think it'd be great if we could make a handout for those and send it out after the webinar and post it on our website.
We sure can.
Additional website. Okay, great. One question I was interested in, what a wonderful presentation. I was just really struck by the trauma with which your patient went through, and loved that you were so proactive working with him, Susan, to get him reinstated his job, even though it didn't work, and that you also referred him to mental health care. Could you just talk, or could someone or all of you talk about how this group of, it's a very diverse group, of course, but how accepting is a refugee or someone born overseas of mental health services? I'm wondering if this is somewhat of a rarity overseas, if there's more stoicism and people not reaching out for help when needed. But I know it is a diverse group. Perhaps you could talk about your experiences and ways that people could help engage their patients in mental health services.
Yeah, I'll start, but I'd be happy to hear the audience talk about it too. We actually, at my county, a few years ago, got an ORR grant to set up survivors of torture center, and it had a fair amount of success. As you said, there was some real reluctance for people going, and it totally depended on which country they were coming from. I think we had more success for people, and this was several years ago, that were coming from Asia than we did from Africa. Though we did have also some success for people coming at that point from Afghanistan. I remember there was one woman in particular that I think really got a lot of support from it. Unfortunately, the funding ran out and we weren't able to continue that. We do, and I know, I'm not sure if Drew Posey talked about it, but we have been trying to develop a tool for overseas to do some simple checking as far as whether or not there are any signs of mental illness. We have developed one as well at our county health clinic, but as I said, we lost the ability to refer them, so it's been a bit of a struggle. I think it depends on the level of severity as to whether or not people actually will identify the need. Within our county, we've had people that have actually committed suicide and was never identified. So it's as it is a problem in the U.S., I think it's a problem overseas. But would welcome to hear what any others from the audience experiences have been.
I want to highlight that we have a webinar. Our next webinar in this series will be on TB and trafficking by Dr. Mike Lizardo on March the 7th. We have not sent that announcement out yet, but we will soon thereafter. And after that, we're planning on having some different webinars. Dr. Ashton will talk about hepatitis C. We will probably have someone talk about transplant, diabetes, and HIV. But we're also planning on having a webinar that focuses on TB and mental health. And so it may be that we reach back out and include our current speakers, since so much of our population is foreign born, really delve a little deeper into this. So I also wanted to get back to some questions. I see there's a question that says, I believe and agree with everything stated on identified barriers. Do you have studies or evidence supporting these barriers? For example, highlighting how belief in Western medicine, risk of losing jobs, stigma, et cetera, might affect TB. This person is really looking for some resources if you have any links.
Yes, it was really just a number of different studies that I was looking at, and I'm more than willing to share those. That I have the full, I don't have the full citation on me at the moment, but they were from various studies. I think one was Morris MD et al. And Al Broussard T et al. They're at the bottom. They're cited at the bottom of the slides. But
yeah, and another a source you could go to. I think you probably saw a reference to a book chapter that I wrote with Michelle Geyer. It's Health in Emergencies. Humanitarian. In emergencies. Is that, I can't remember the name. But anyway, there is a chapter in that as far as mental health, and I would refer you, health and humanitarian emergencies. Yeah, there is a chapter that Barbara Lopez Cardosa wrote with Richard Maleka, who has done an awful lot of work on mental health in emergencies. You could even Google him for some of the work that he's done. But if you're interested in that book chapter, I could see if, well, I don't know if it's copyright.
So get it to us. We're not allowed to post it as a handout, of course, but I think if you could get a copy of that, and I have a copy of Susan's chapter as well, you'll let us know. We are able to share these one-on-one. We just can't disseminate it broadly.
Yeah, let me know, and I can get it from Barbara.
Yeah, and then Ann Scarpita, if you would like to get some of those resources and you want to reach out to me, I can connect you with Allison. A couple more questions. I see that someone has commented that it should be clarified that refugees are legally able to work in the United States upon arrival. Do one of you want to talk about how refugees may come in and the first few months that they're here, how they're set up initially?
Sure. So as you know, or maybe you not know it, so refugees basically have 3 months of provisions for them. They get an apartment, they get it furnished, but within 3 months they have to find employment because those provisions stop. They continue to have the refugee medical assistance for 8 months, but they have to be employed and basically self-sufficient within 3 months. There is additional grants they can apply for, but it's not, the TAFNI, I think is what it is, but it's harder for them to get that. But it's especially now with a lot of them coming in from the Middle East, a lot of them are extremely highly educated or were, and the only jobs for the most part are like what happened to Mr. JM, though he didn't have much of an education, but an awful lot of them were very much labor jobs.
Yeah, no, I think that's very helpful. There's another nice question that says, how will the fear of becoming a public charge impact our ability to provide care, and what might be the resultant impact on the general U.S. population?
Oh, man. I don't think everyone. I mean, we share your fear that you have for this becoming, and you know, it's very interesting. This also happened just before World War II. That this was when that act came about. So it's interesting that it's now being revisited. And yes, it is. You know, at some point we have to decide, are we a humanitarian society or not? And I don't think we've made that decision. Hopefully we haven't made that decision yet.
Yeah, I see a follow-up comment one of our participants made, talking about, as a physician, having the moral and ethical obligation to care for all refugees as well as legal residents, and that in Middle America, illegal adults and children with LTBI and HIV that are unvaccinated are increasing and can be supported by religious groups which frown on government intervention, and also the challenge of, in a state like that, of having very limited resources to provide care for all these individuals. So this is a real challenge, and it is one of the things I love about public health is how providers and programs can really look at what the problems are and identify resources, even if they're not their own, reach into the community and really try to bridge some of the gaps the government's not covering. And you know, I love public health being very altruistic. Any other comments from you all?
Yeah, I mean, TB is a disease. It's a public health condition. So I mean, I think as us who are in public health, and I'm pretty sure for all county health departments that because TB is such a public health issue, that care is given for free. At least it is in all of Georgia, and I'd be surprised if that's not true for other county health departments throughout the U.S.
There's a long question that is from Ukraine. What I'm going to do, if that person could send me their DC an email there, I'm going to see if we can answer that offline because it's a very specific question. And then we have one more that was talking about a patient that came in with a biopsy, a suspicion for extrapulmonary TB, and it was sent for AFB smear that was positive, but they were really surprised that no one went to the next step to process for a culture. Is this not a protocol for labs? And do we have experience with this? I'll just say that I do see this, and it's very unfortunate, especially when you're talking about biopsies and surgical procedures, that people will put the sample, surgeons and OR staff will put the samples in a fixative, which means it's very difficult to get the culture. But I will say that if you can get that sample, we can send those to CDC, and they can often use a molecular methodology to get DNA out of many of those samples. So if this happens to you all, please reach out to one of your centers of excellence or directly to the CDC, and we can help connect you to the infectious disease pathology lab there at CDC.
And you're not.
Do you guys have any other comments on that?
I had one of those patients as well.
Yeah.
I work at the CDC, but in the county, it was a biopsy of a liver lesion, and the CDC, the pathology, was able to make the diagnosis that it was M. tuberculosis complex, but unfortunately there wasn't enough DNA in order to run the resistance, the PCR for resistance, but they were very helpful for at least getting the diagnosis of what it was.
Yeah. So infectious disease pathology lab at CDC. Okay, one last question. We're at our time of 1:30 or 12:30 or 11:30 or 10:30, depending on where you all are calling from, and I can't even calculate for Greece and Ukraine. But Susan Cookson, there was a question about the method you used for calculating the estimates for the proportion not detected, and a question about whether or not we should be using this in the U.S. as well to look at weaknesses in our system.
Yeah, I mean, so within the U.S. we're at 94%, so we're very good. But Susan, do you want to?
No, if you're asking about the percent of all TB cases that are missed, that data is data that comes from the WHO. It's WHO estimates. It's based on an algorithm that includes the notification rates from different countries and also lots of adjunct data, including prevalence surveys, inventory studies, many of the kind of studies that our group here has been working in collaboration with the WHO to develop.
But remember that those estimates are national estimates. So with a country as large as the United States, I don't think you could really use the national estimate of the incidence for your particular region. So I would steer against that, as I showed with what happened in Tanzania with Kigoma. They had a much lower notification rate than the national, but personally I think that was more because they weren't identifying the cases, not that they actually had a lower incidence. So unless you do, as Susan said, a prevalence study within each of the states, and we'll never do that because our surveillance system is so good. Yep. It's going to be difficult to use WHO estimates to try to understand. But nationally, if you look at it, it's the last time I calculated, it's not these latest data, but last year's data, we were at 94%. So we're pretty good.
At case finding.
Yes. Yeah. Yes, absolutely. Not so good at LTBI, but hopefully we're going to get there. Well, I want to thank our participants again for coming, and I definitely want to thank our three speakers, Dr. Cookson, Dr. Maloney, and Ms. Hoskins. I think that this was just an absolute wonderful webinar, and it will be archived on our website within a week. And ultimately, we'll be turning this into a product where it can be viewed for credit, and it'll have an interactive tool to enable people to answer questions and learn more and go in more depth if needed. That is our plan with all of this webinar series. Again, March 7th will be Dr. Lizardo talking about trafficking, and then we'll have the rest of our schedule out. We're planning on doing webinars about every 2 months in this series. I hope you've enjoyed it. Please give us ideas for topics that you are interested in. And if you have additional questions for any of our speakers, please feel free to send them to us, and we'll connect you, get the answers to your questions.